अभी बंद हो गई का। Hi everyone, good evening to all and greetings from Varanasi. So welcome to the Mahamana case discussion series, and it's as some of you might be aware that it's a bi-monthly case series which is done on alternate Thursdays every 15 days, and it has two components. First is an invited talk by an expert followed by a case discussion. So for the talk today we have with us Dr. Akhil Kapoor. Dr. Akhil Kapoor is Associate Professor at our Institute in Medical Oncology, that is MPMMCC Varanasi, and he'll be giving his talk on management of unresectable advanced oral cancer, role of chemotherapy and immunotherapy. So, Dr. Akhil Kapoor, welcome and over to you.
Thank you, Dr. Komal, for inviting me. So, this is a topic which is definitely close to any medical oncologist heart, because we see a lot of head and neck cancer patients which are really advanced. So it is a very common that in medical oncology OPD, for example, we see close to 700 patients per day in medical oncology OPD at Varanasi. And here, out of 700, close to 150 to 200 patients would be advanced head and neck cancers which are not resectable. So you can understand the bulk of patients. And just to give a insight, we started a study on triple metronomic treatment where the patients were to be randomized in two arms, triple metronomic versus physician choice, and we were able to complete the enrollment in 3.5 months, 214 patients. So a study for 214 patients, which takes years to get enrolled, we could enroll the patients in just 3.5 months. So the burden of this cancer is definitely very high in this area, and definitely a large number of patients require some form of treatment. So we'll see how chemotherapy has evolved, what are the other treatments, immunotherapy and targeted therapy, and we'll see the data for the same as well. I will try to keep it simple and short. I will try to finish in 20 to 25 minutes. So we'll come to the first line therapy options, where we know that a substantial proportion of patients with locally advanced head and neck cancer will experience relapse or metastatic disease at some point of the time. Stage 1, stage 2, they are presented in around 30% cases only, while stage 3 to 4A has the bulk of the disease. Overall, 60% patients are in this stage, and cure can be achieved in only 25% of these patients. So as I just highlighted, recurrence rate is extremely high. Even in early stage cancer, it is to the tune of 1 in 5. So out of every 5 patients in early stage cancer, that is stage 1 and stage 2, around 10 to 20%, that is 1 in 10 or 1 in 5 will recur. And this recurrence rate is much more higher in locally advanced patients, that is stage 3 and 4A, approximately to the tune of 50%. While median survival is to the tune below 1 year in such patients. Now the advent of immunotherapy has somewhat changed the picture, but the utilization of immunotherapy in routine practice to all the patients is not feasible till now due to the cost issues. So there was an initial study. What do the patients want? This study was conducted at TMH from medical oncology team. What was the main expectation? Was that prolongation of the life and symptom relief. So these two are the main areas which is required by any patient for advanced head and neck cancer who is planned for palliative intent treatment. Let's see the systemic treatment, single agent therapy. Data, there is data for cisplatin, there is data for methotrexate. I'm talking of treatment naive patients or patients who have undergone only surgery or only radiotherapy or surgery followed by radiotherapy alone. That means systemic therapy naive patients. The response rates of single agent drug is to the tune of 15 to 30%, and doublet combination has been utilized, but it does not add much value. So whether the patient is receiving only carboplatin or cisplatin versus patient is only receiving doublet paclitaxel carboplatin does not make much sense differences, though some increase in the response rate is expected by the doublet treatment at the cost of somewhat increased toxicity. This is what very clearly evident. So there is data of cisplatin 5-FU versus carboplatin 5-FU and single agent MTX. all seem to fare nearly similar. Though cisplatin 5-FU, which is the most toxic usually out of these three regimens, they tend to do somewhat better, but still not so good. So there was a data which you can see. This is a E1395 study. These are some landmark studies which need to be kept in mind by all the head and neck SRs and residents. That this was a randomized phase 3 evaluation of cis plus 5-FU versus cisplatin plus paclitaxel in advanced head and neck cancer. This was published in JSU in 2005. This is an intergroup study. You can see on the screen that complete response rates were to the tune of 6 to 7%. And there was not much differences between cisplatin 5-FU versus cisplatin paclitaxel. And what is to be understood is that by omitting 5-FU and utilizing paclitaxel, what we are able to achieve is that it has much logistic constraints are reduced, because 5-FU infusion for 3 to 5 days requires PICC placement, and 5-FU has its own myelosuppression. That means reduction in hemoglobin, WBC, and platelets, which is not so high with paclitaxel. Paclitaxel is known to cause neuropathy. Therefore, we need to be careful. If patient is a diabetic from the beginning, there are high chances of getting neuropathy due to paclitaxel. That is what we keep in mind. You can see there's no differences in the outcomes. That is why both of these became either two can be utilized. In our practice, we utilize maximum times paclitaxel plus carboplatin or paclitaxel plus cisplatin. Sometimes docetaxel is also utilized. There's data for the same as well. So doublet therapy, some increase in response rate, but not improve the survival rate. There's no clear-cut data on quality of life. So these are the options. Now coming to the options that improve the survival of the patients. So this is another landmark paper which needs to be kept in the mind. This is 2008 paper, platinum-based chemotherapy plus cetuximab by Vermurken et al. And you can see a large randomized study, 222 patients in each arm, cis 5-FU plus cetuximab versus chemotherapy alone. You can clearly see there is some improvement with addition of cetuximab. This is in terms of overall survival. So first time some data came where addition of one drug, which is cetuximab, led to the improvement in the overall survival. You can clearly see this data. This is actually somewhat useful, and it helps us to understand that yes, there is one targeted therapy which can add to the life of the patients. If we see the oral cavity, for oral cavity, this data is the strongest, because we know the oral cavity patients, these have usually these are unresectable, not exposed to radiotherapy, and these patients will do well with this combination. So for oral cavity cancer, cisplatin-based chemotherapy plus cetuximab has become one of the standard care and very commonly utilized in the routine practice. Again, toxicities, if we see, the toxicity rates with 5-FU based combinations will be high as expected. So grade 3, grade 4 toxicities will be to the tune of 30 to 40% at least. And other incidences include skin reactions. So this is extreme regimen, which was the first randomized trial to show that level 1 evidence of addition of cetuximab to chemotherapy. Then let's see, after targeted therapy, let's some data of immunotherapy. Pembrolizumab, Keynote 48, very talked about the study, but Tress et al. Presented in published in 2019 in the Lancet. You can see this is a trial with 3 arms, Pembro versus Pembro plus chemotherapy versus extreme regimen. So in the extreme regimens, you can see cis or carbo was utilized along with 5-FU and cetuximab, while in one arm Pembro plus chemo was given, which was cis 5-FU, and the third arm was Pembro alone. And there was 1:1:1 randomization. The patients were stratified for PDL1 expression. So what is PDL1? PDL1 is expressed on the tumor cells. And what is TPS? Tumor proportion score. So a pathologist calculates the tumor proportion score by seeing in the slide. He or she can see what proportion of the tumor cells are actually getting PDL1 expression. If it is to the tune more than 50% versus less than 50%. So this study was a randomized study with primary endpoint of overall survival and progression survival. Both co-primary endpoints were taken. If we see again, PS1 patients were to the tune of 60% in both the arms, and PS0 and PS2 patients were also included, but they were a very small number. And P16 positive patients were around 20% in each arm. So that is another point which needs to be taken into account, that P16 positive patients have what somewhat better outcomes. We know that from the disease biology itself, and they contributed equally around 1/5 on each arms. And also, as we know now that TPS is TPS more than 50% will select patients who will respond somewhat better to immunotherapy. So that was also somewhat similar, 22% in each of the arms. So the data is very well balanced, which is very clear that these patients will be equally distributed across all arms. Coming to the data for CPS more than 20. So what is CPS? I told about tumor proportion score. This is combined proportion score. Combined proportion score is tumor cells taking a stain. Apart from that, there are other immune cells, that is either lymphocytes or macrophages, which are taking the stains. So the tumor microenvironment is important. Not only the tumor cells, but tumor cells will be surrounded by infiltrating lymphocytes, TILs, which is very important. And if TILs are there and they are also taking up the stain, it will also be a marker of increased chances of immunotherapy response. So when we are writing for PDL1 testing in our patients in advanced head and neck cancer, we write PDL1 testing by CPS. So that is what we do in our practice now. TPS is practiced in lung cancer as per the data, and the CPS is more important in head and neck cancer because of the tumor microenvironment. So this is what I wanted to highlight. And you can clearly see there is complete separation of the curve with the addition of immunotherapy versus extreme regimen. And you can see at 3 years, survival with immunotherapy and chemotherapy was to the tune of 33%, and that was meager 8% at 3 years with chemo plus cetuximab. So it is very clear, addition of immunotherapy in at least CPS more than 20 is very causing significant differences in the outcomes. The difference will reduce somewhat if only CPS 1 or more are selected, and overall population is to the tune of 10 versus 22%. So yes, there will be differences, but the quantum of benefit is higher for higher CPS. So if we see the data, CPS more than 20 and CPS more than 1, we can clearly see, yes, overall immunotherapy is leading to some improvement in the outcomes. So if you see the hazard ratio, which is very useful in determining the quantum of the benefit, for CPS more than 20 is 0.61, CPS more than 1 is 0.74, and overall it is 0.83. So what is need to be understood is that if we see the toxicities of the treatment here, both the regimens, in the extreme regimen, it was cis-5-FU plus cetuximab. In keynote 48, pembrolizumab was given along with cis-5-FU. So there were further studies in the extreme, actually TP extreme regimen. Paclitaxel plus carboplatin given study with pembrolizumab till now, but most of the time we apply pacli carbo plus pembro in routine practice, not cis-5-FU in the routine practice because of the obvious reasons. Now coming to the main point, that how many patients of who are actually candidate for immunotherapy are actually able to receive immunotherapy, and this data is to the tune of only 3% in our setting, because you can clearly understand the cetuximab now it is available at generics, so the cost has reduced, while when this data was published, cetuximab was very costly. Pembrolizumab is exorbitantly costly now, but support programs are also, the cost is reduced, but still it is out of reach for around 97% of our patients. That is why there was need of development of some form of treatment which can be utilized in a large number of patients, our patients. So there was initial studies for phase 2 study for comparing metronomic chemotherapy. What is metronomic? Metronomic means continuous low dose administration of chemotherapy tablets, so that there is not of much requirement of holding the treatment, and there is continuous exposure. So just wanted to highlight here, if patient is receiving chemotherapy, what happens, sometimes we clearly see the patient, when the chemotherapy is administered, patients tend to respond, but towards the after 10 to 15 days, again there is a rapid increase in the tumor, the local mass. So that is very common in the practice, while the concept of metronomic is that instead of giving the entire doses together, separate it out continuously so that no patient develops too much toxicities, and also there's a continuous exposure of the tumor cells to the chemotherapeutic agent, so that they do not tend to over proliferate at one point of time when there's no administration of treatment. So that is the concept of metronomic, and here it was compared in phase 2 study. It was found that metronomic treatment was better than even platinum, single agent platinum. So then there was a phase 3 non-inferiority trial of low-cost metronomic treatment versus single-agent chemotherapy in recurrent metastatic head and neck cancer. This was a non-inferiority trial. You can see that overall survival was improved with the utilization of metronomic treatment as compared to single-agent IV cisplatin. So that became one of the important outcomes in our practice. When patients are not able to utilize on cetuximab or pembrolizumab, metronomic treatment is what we utilize. This is very clear that it adds to the life and it is causes minimal toxicities. Though toxicities are there, erlotinib, which is a component of the metronomic treatment, will cause rash. We utilize 100 milligram most of the time. 150 milligram is the dose which is usually recommended, but we utilize 100 milligrams so that the patient does not develop too much of skin toxicities. You need to understand cetuximab is a EGFR inhibitor. Erlotinib is also a EGFR inhibitor. Cetuximab is a monoclonal antibody against EGFR, while erlotinib is a tyrosine kinase inhibitor of EGFR. So toxicities will be there since EGFR is expressed in the skin. So all the cells, there will be side effects on the skin clearly with the use of anti-EGFR drugs. So that is why these patients develop paranoia or skin rash, maculopapular rash, which are very common. That by seeing the patient, you can understand that patient is on either cetuximab-based treatment or drugs like erlotinib or gefitinib. So this is very clear, and that has actually led to improvements in the outcomes at improved toxicities and very low cost. Monthly cost of oral metronomic treatment is to the tune of only 2,000 and 2,500 rupees, not much high, and can be taken by most of the patients. The toxicities are there, as I highlighted. There can be some hyponatremia if the patient develops mucositis. These patients are already exposed since they have pre-existing multiple comorbidities and problems. These have already received radiation most of the times. They have a pre-existing mucositis, which can be worsened by the drugs like methotrexate as well. So quality of life, if we see, the quality of life with oral metronomic treatment was much better sustained than the intravenous chemotherapy. When we are utilizing oral metronomic treatment, this is another important point which we highlight, that the quality of life is improved with the utilization of this treatment. Coming to the platinum refractory disease, again, there is now data for nivolumab. This is another important data. Yeah.
Oh, sorry, please continue, Dr. Akhil.
Yeah. So this is another data for nivolumab for recurrent squamous cell head and neck cancers. You can see this data where you can clearly see in patients who are platinum resistant, nivolumab versus standard of care treatment, there is complete significant separation of the curves. This was 2:1 randomization, and it is very clear that second line immunotherapy is better than other forms of treatment, mostly docetaxel or other treatments which are utilized. So there was further study of pembrolizumab versus other physician choice treatment. It also showed similar outcomes. The curves are similar to the previous data for nivolumab. Now coming to the metronomic treatment in platinum insensitive failures, that is data you can see. This was a initial study, phase 2 study. A sample size of 100 patients was selected, and it was found that yes, metronomic treatment is good for even with patients with platinum refractory disease. And then further there was data where what I have highlighted, erlotinib 150, we mostly utilize 100, celecoxib 200 milligram per oral BD, methotrexate with 9 mg per meter square. This led to a 3-month of PFS rate of only 70% and 6-month OS of 60%. So this triple metronomic treatment came into the picture and changed the way we treatment. Now coming to the last important part, because we know that, as I've highlighted, either full dose immunotherapy, pembrolizumab or nivolumab will cost significantly, will cost around 2 lakh per month, which is out of reach of 97% of our patients. So what to do? So this study was conducted. This is randomized trial published in JCO in 2020. So this is very, very important data for us, where we can utilize 40 milligram of nivolumab, one vial, which cost only around 37,000 rupees. One vial to be utilized in 2 times. 20 milligram utilized 3 weekly, then the same vial can be utilized next time as well. So the cost will be reduced to 37,000 for 6 weeks apart, in addition to in addition to triple metronomic treatment. And that clearly showed improvement in the survival from 1 year of meager 16% without immunotherapy to close to 45% with addition of low dose nivolumab. That is why our colleagues will, head and neck and other colleagues will clearly see the increased utilization of low dose nivolumab in our practice, because it is supported by randomized evidence from our own trials, and that is published in JCO, and that actually led to a significant stir throughout the world, and a lot of patients who were not able to receive immunotherapy were able to receive low dose immunotherapy, and the proportion of patients getting some exposure to immunotherapy due to utilization of low dose nivo has increased from just 3% to close to 27%. So our patients, around at least 30%, 1/3 of the patients are now able to receive some form of immunotherapy. It is expected that nivolumab generic will come by next year. Then the utilization of generic nivolumab will lead to significantly increased utilization of immunotherapy in the routine practice. And the best part is that the toxicity of this regimen is not high. If you can see, chemotherapy, triple metronomic therapy plus immunotherapy, the grade toxicities were even actually less than triple metronomic alone. So these were not significantly different. It was similar. So addition of low dose nivo did not lead to increased toxicities as well. So there are some molecular targets, but not very well established, which I wanted to highlight here. For example, TKIs like sorafenib, sunitinib, vondatinib. These are utilized mainly in thyroid cancers. Some treatments option. There is one data for tipifarnib, which is a precision therapy for HRAS mutant head and neck cancer, and it had got approval recently. I'm not. There is also some data of gefitinib combined with methotrexate, but that has also not led to much significant outcomes. Even capecitabine, lapatinib, these all drugs have also been tried, but not much effective. Afatinib, it's another. If patient, we see that patient is having deranged creatinine, both celecoxib and methotrexate cannot be utilized. In that case, we prefer utilizing single agent afatinib, based on Lux head and neck 3 data, where afatinib has somewhat better activity than other agents like methotrexate. So afatinib we usually keep reserved for patients who are not candidate for triple metronomic because of increased creatinine. So this is the data. And afatinib. Other important treatments are early utilization of palliative care, which has already shown survival benefit in lung cancer, though it has not shown great benefit. But yes, these patients have a lot of symptom burden, and they require continuous support for their treatment, and incorporation of palliative care team is really, really important. And there is clear some important data that this though did not resulted in outcome improvement, but definitely there will be some improvement in the patient satisfaction and the distress management. So distress management is another important practical approach which needs to be kept in mind, and it is very important. Just to give a summary of the overall view, if patient has received platinum and patient has not relapsed within 6 months, it is known as platinum sensitive disease. While platinum received less than 6 months and patient has recurred, for example, patient underwent surgery, then underwent CTRT adjuvant treatment and has recurred within 6 months, it will be considered as a platinum refractory disease. In such cases, the options include immunotherapy or triple metronomic therapy, and now triple OMCT with low dose nivolumab is also an option. If patients have higher DFI, disease-free interval is more than 6 months, then the patient has mild to moderate symptoms, then we can decide based on immunotherapy plus chemotherapy. That is most commonly utilized, pembrolizumab. But if PDL1 is unknown, disease burden is high, most of the time we utilize TP extreme regimen in our practice, that is paclitaxel carboplatin with cetuximab. That is what we utilize. In patients who are borderline performance status, platinum ineligible with significant financial constraints, the options are oral metronomic treatment or best supportive care versus triple metronomic treatment with low dose nivolumab. All these are considered on the basis of availability of the resources and patients and families' keenness for treatment. I think I tried to highlight all the important points with this, and I would like to stop here. If there are any questions, we can take one or two.
Thank you, Dr. Akhil, for such an elaborate talk. And the last slide especially covered, everything in a crisp manner, like how to go about palliative chemotherapy, what options are there, palliative immunochemotherapy. Thank you so much. So again, if there are any questions from the participants, they can put in the chat box. We'll wait for 2 minutes. So I think if there are any questions, please drop in the chat box. Dr. Akhil, please wait for some time. In the meantime, I'll introduce the moderators for the next session, which is a case presentation. So today's case presentation is on advanced oral cancer, and it will be presented by Dr. Sunita Thakur, who is a resident in head neck oncology at Kidwai Memorial Institute of Oncology, Bengaluru. Dr. Sunita, you're there?
Yes, ma'am. Can you hear me?
Yeah, please, you can share your screen.
Sure, ma'am.
And to moderate the session, we have with us Dr. Devendra Chaukar. Sir has been a teacher of ours and many other like us. Sir was presently the head of department at Tata Memorial Hospital for Head Neck Surgical Oncology. Now he has moved on, and presently he is the director of Head Neck Surgical Oncology at Nanavati Max Institute of Cancer Care, Nanavati Max Super Speciality Hospital, Mumbai. Welcome, sir.
Hi. Thank you for the introduction. Akhil, great talk. Komal, can you hear me?
Yes, sir, we can hear you. Yes, sir.
Yeah,
Thank
thank
you,
you.
sir.
And Akhil, great talk. And I would request Komal, if you can ask Akhil to continue to be on the panel here to ask questions. Since it's an advanced oral cancer, maybe Akhil can contribute in the questions.
Yes. Dr. Akhil, please, if you can spare some time to be on the case discussion.
Sure.
Thank you so much. Next, we have Dr. Shivakumar Thiagarajan. Sir is professor in head neck surgical oncology at Tata Memorial Hospital, Mumbai. Welcome, sir.
Hi, good evening to all.
So, next we have Dr. Mitali Dandekar. Ma'am is senior consultant head neck surgical oncology at Paras Cancer Center, Patna. Welcome, ma'am.
Yeah, hi Komal and good evening everyone.
So I think, Dr. Akhil, there are no questions to you in the chat box. So I think we'll proceed to the case presentation. And thank you once again for such an elaborate talk. And thank you once again for sparing your time to be on the case presentation.
Thank you, Kamal. Thank you.
So, Dr. Sunita, over to you.
Hello.
Sunita, hi, you're audible, but your screen is not shared. Please share your screen.
Yeah, ma'am. After sharing my screen, I was not able to. I was unmuted actually, so I thought I'll try it once more. Am I audible now? Hello?
Yeah, you are audible, but your screen slides are not seen, Dr. Sunita.
Uh, is it visible now?
It's not visible to me, at least.
Your presentation slide is not there. I mean, we can see your screen in which your Zoom screen is open. Your PPTs are not, your PPT is not there.
You need to share your screen, Dr.
Yeah.
Sunita. You had your
Is it
slides on,
visible
and then
now?
it was not lost in between.
Now is it visible, sir?
It's still loading the slides. It's still not visible yet. Is your connection all right there? Your
Yes, sir.
internet connectivity seems to be an issue because
I'll try once more.
Dr. Sunita, you can mail it to Dr. Komal so that she can share the screen.
Yes,
Yeah,
sir.
you can do that. Sunita, are you mailing me the presentation?
I'm mailing you, ma'am.
Okay.
Just 2 seconds. Ma'am, I've mailed you. Hello?
Sunita.
Ma'am, I've mailed you my PPT.
Yeah, just let me download it. Shiva sir, and Chaukar sir, can we start with the presentation? I'll try to download it and display it. Meanwhile, you can start talking with the history at least.
Yeah, sure.
Right. Okay.
Yeah, Sunita, please start with the presentation. Sunita, can you hear me?
Yeah, yes, ma'am.
Please start with your presentation. I mean, don't share your screen. Just
Okay.
start speaking.
Okay. Good evening, everyone. Today I'll be presenting a case on advanced buccal carcinoma. A 61-year-old female housewife. She is a resident of Dodda Karnataka. She presented with chief complaint of ulcer in the mouth for 4 months. The patient was apparently well 4 months back when she noticed an ulcer in the right buccal mucosa, which was insidious in onset, gradually progressive to attain its present size of around 4 into 3 centimeter. It was associated with pain localized to the site of the ulcer. It was mild in intensity, aggravated on chewing, and relieved on taking oral analgesics. There was no history of sharp tooth, loose tooth, or earache. There was no history of any neck swelling. There was no history of difficulty swallowing, change in voice, or difficulty breathing. There was no history of cough, hemoptysis, bone pain, loss of appetite, or weight loss. She gives a history of betel nut chewing for 20 years and she has stopped since 1 year. There are no other addiction history. There was no history of diabetes mellitus, hypertension, jaundice, seizures, asthma, or any known allergy. She doesn't give any prior treatment history and there is no family history of malignancy. That was with the history, ma'am. Can I proceed?
So is that your history of presenting illness?
Yes, sir.
Is that all?
Yes, sir.
Right. Uh, okay. That was like a short case. But then my question, you said there's no history of, what did you say about family and malignancy?
There was no family history of any malignancy, sir.
So do you expect any such thing in in oral cancers?
So there are certain genetic predispositions that
Like?
patient might have, like Fanconi's anemia, Lee-Fromenis syndrome, Bloom syndrome, ataxia-telangiectasia, xeroderma pigmentosa. All of these syndromes might have a genetic predisposition, sir.
Yes, that's true. For oral cancer, does xeroderma pigmentosa predispose to oral cancer?
No, sir. Mostly skin cancer, sir. BCC.
Exactly. So the point of me saying this is you should avoid unnecessary, negative histories. Your negative history, we've been saying this time and again. Your negative history that you ask should be pertinent and meaningful to the case that you're presenting, and not just any random question, right?
Yes, sir.
Okay. And how about the history of habits? Can you just elaborate on that?
So she gave history of only beetle Erica nut chewing for 20 years, and she was not, according to the history, she was not a regular intake. She gave a history that she used to chew once in 2-3 days, so occasional beetle nut chewers. No other addiction history as such.
Right. So, I mean, how does arecanut, contribute in the carcinogenesis process?
So arecanut contains certain alkaloids and tannins. Alkaloids like arecoline, arecidine, guavacoline, guavacane, and tannins. So all of these arecoline and arecidine, they have their arecanut associated nitrosamines and nitrates. They lead to formation of DNA adducts, DNA strand breaks, and also the betel nut extract, which contains certain procyanidins, which leads to release of reactive oxygen species that also leads to DNA strand break. So all of these will lead to development of lead to carcinogenesis, which is for because of erica nut chewing, sir. Also predisposes to oral submucosal fibrosis, which is itself a pre-malignant condition. Then that per se will also lead to development of invasive malignancy.
Good. Yeah. Any other questions from the others, sir? Chaukar, sir?
No, go ahead.
Mitali?
Yeah.
Mitali, go ahead.
So Sunita, I heard you saying that the patient gives no history of earache, and you
Yes, ma'am.
presented that the patient has cheek swelling or cheek ulcer. Can
Yes,
you
ma'am.
again, as Dr. Shiva mentioned, can you tell us why you mentioned about earache? Why did you ask the patient about earache for a cheek ulcer?
So buccal mucosa cancer, if it involves, if it's eroding and going towards the lingual side, ma'am, then it might lead to the involvement of the lingual nerve in advanced cases. So in that cases, the pain might be referred to ear by the afferent through the lingual and efferent through the auriculotemporal. So she might she might say the pain might be radiated to the ear.
Okay. Okay. I think you can move. Yeah. Go
I
ahead.
can start with the examination, ma'am.
So
Yeah.
before you do that, always, before you go to the examination, you can just give a brief summary of your, case, the history, that is, just with the, salient points of the history, and then go on to the, examination, and at the end of the examination, an overall summary, and then your diagnosis. So that will help putting things in perspective for you and as well as for the examiners. So if you can just give us, brief summary of this.
Yes, sir. My patient is a 61-year-old lady. She had chief complaints of ulcer in the mouth for a duration of 4 months, and also had gives a history of Erica nut chewing for 20 years. There is no other significant history as such.
Yeah, that should be good enough. Yeah, proceed,
Yeah.
please.
So proceeding with general physical examination, when examined, she was well oriented and moderately built and well nourished. Her vitals were stable. Performance score ECOG of 1. There was no pallor, no icterus, no cyanosis, no clubbing, or no generalized lymphadenopathy. Examination of the local examination of the oral cavity. On inspection, mouth opening was 3.3 centimeter. She had poor oral hygiene. She dentition, it was a, she was it was a dented mandible, and there was a missing left lower second premolar, and there was no other loose tooth present. On examination of the lesion, an ulceroproliferative lesion was seen over the right buccal mucosa, measuring of around 8 into 3 centimeter with irregular margins and everted edges, extending anteriorly till commissure. Posteriorly, it was around 2 centimeter away from RMT, involving the lower gingivobuccal sulcus. The upper gingivobuccal sulcus was free. In around the commissure, skin puckering was present of around 2 into 2 centimeter. Examination of the contralateral buccal mucosa and the other subsides of the oral cavity was normal. There were no fibrotic or white bands present anywhere else in the oral cavity. On palpation, my inspectory findings were confirmed with the same measurements. Tenderness was present over the growth, and it bled on touch. Sensations were present on bilateral cheek and chin, respectively. Examination of the neck. On inspection, there was no visible lymphadenopathy or swelling in bilateral neck. There was no scars, sinus, fistula, or dilated veins. On palpation, a single lymph node of around 2 into 2 centimeter size was palpated at level 1B lymph node station. It was firm, non-tender. It was mobile, not fixed to underlying skin, overlying skin, or underlying structures. The skin above the swelling of the above the node was normal, and there was no local rise in temperature. On Hopkins rod examination of the larynx, hypopharynx, and oropharynx was within normal limits. And systemic examination.
Before you go there, Smita, the disease you said is reaching the lower alveolus, right?
Lower GB, yes, GB sulcus, yes, sir.
The GB sulcus. No, is it okay? Sulcus, and is it abutting the alveolus, or is it
Yes, sir.
crossing
There is
the?
paracondylar spread, sir.
Sorry, come again.
So there is the disease is mainly, it is not crossing the lingual plate, sir. It is sitting over the gingivobuccal sulcus.
So lingual plate is free. Is that right?
Yes, sir.
Yeah, and so that means, do you have anything to comment on the paramandibular? Is there paramandibular soft tissue disease? Is there or not?
Yes, sir. Paramandibular disease extension is there, sir.
So okay, you need to comment on that.
Yes, sir.
Because that will that will have some amount of bearing in your management, if at all. I mean, that's an important clinical finding as well,
Yes, sir.
right?
Yes, sir.
And you said there is no loose tooth, so that is
There is
again an
no.
important finding, because there's, if there what is the implication of if there is loose tooth in the presence of disease in the lower GBS?
So this will provide a route for entry of the tumor into the mandible, sir.
So that is fine, but probably it has already invaded the mandible. That's why the
Already
teeth is
invaded,
loose,
and then yes,
right?
sir.
In its
Yes, sir.
absence, if there is disease in the lower GBS and you're saying there is paramandibular disease, so that means that probably you don't know. You need to confirm it with imaging, but as of now, there is paramandibular disease.
Yes, sir.
Is that right?
Yes, sir. For yes, sir.
Yeah, you need to say. I mean, say all these points in your findings.
Examination. Yes, sir.
If there are no any other question from
So how do you assess
Mitali or some?
paramandibular disease, Sunita?
Ma'am,
You said
paramandibular. Yes, ma'am. Paramandibular disease on clinical examination, we can do a digital palpation of the lingual and the buccal plates of the mandible. We can see a bicortical expansion of the mandible, and also the thickness and the vertical height of the mandible. If palpated, there should be a significant spread antero posteriorly as well as supero inferiorly,
so.
ma'am.
This what you're describing is for infiltration into the mandible or paramandibular. What is the difference between the two? If you bimanually palpate the lingual as well as the buccal plate to see for cortical expansion, are you describing the process to evaluate infiltration into the mandible or paramandibular disease?
That is, ma'am, infiltration into the mandible.
So how do you assess paramandibular disease?
Paramandibular disease, ma'am, usually it is a clinical radiological examination where we need to see the tumor across the vertical height of the mandible, if it is involved or not, ma'am. So we can still do a bidigital palpation in which one which palpates the tumor, and the other one we can palpate on the external skin and see uh, the width of the tumor, ma'am, along
Width
the
of the tumor on what? So you see
width
the
of the tumor.
mobility of the tumor on the mandible, whether the tumor
Yes,
is
ma'am.
moving separate from the mandible or it isn't,
Yes, ma'am.
right?
Yes,
And
ma'am.
another thing you mentioned that the patient has a performance status with an ECOG of 1. What does it suggest?
ECOG performance scale of 1 means she is symptomatic, she has some form of pain, but then she is able to carry out her physical activities on a regular basis.
Regular physical activities, right?
Yes, ma'am.
So that will be ECOG 0 or ECOG 1?
ECOG 0 is she has no symptoms at all. ECOG 1 is she is at least symptomatic, ma'am.
Is it totally based on symptoms or the physical activity?
Ma'am,
Performance status.
performance status is basically based on the physical activity, but
Okay.
ECOG, the difference between ECOG 1 and 0 is patient should be symptomatic in ECOG 1, ma'am.
Symptomatic such that it restricts her ability to perform
Physical
strenuous activity,
activity.
right?
Yes, ma'am.
So it
Yes,
is
ma'am.
restrictive.
Yes, ma'am.
Okay.
What is the importance of paramandibular disease, Smita?
Sir, in view of paramandibular disease, when there is extensive paramandibular disease spread of at least more than 1.5 centimeter, then that calls for segmental resection when we are operating the patient, sir. In that case, we cannot save the mandible. We need to go ahead with a segmental resection.
Can you just come again? Sorry.
Sir, in view of extensive paramandibular disease, we need to take a call on a resection of the mandible, sir. Segmental resection is warranted in such cases. We cannot do conservative,
Right.
notch. We cannot save the mandible in such a case.
So when can you do a safe, marginal mandibulectomy, oncologically safe, as well as, once you leave behind the remnant mandible, it should be, it should not undergo pathological fracture. So when is that possible?
Sir, in cases where there is obvious no paramandibular disease spread, there is no cortical erosion, where the tumor is sitting away from the mandible or it's just abutting the alveolar mucosa with minimal cortical erosion, in that case, we can get away with a marginal mandibulectomy. If we do a marginal mandibulectomy, then at least a vertical height of 1 centimeter should be preserved so as there won't be any future pathological fractures.
Right. Okay. So why would these pathological fractures occur?
So because when the height of the mandible, if you're not preserving at least 1 centimeter of the height because of the force of the mastication, sir, then that would lead
Right.
to
Right.
formation, that would lead to pathological fractures.
Okay. Please proceed.
Can I summarize my history and examination?
Sunita, why did you examine the larynx, hypopharynx? You said it's normal. Why do you examine all these areas? Patient had no complaints.
Sir, in case of oral cavity malignancy, especially in advanced cases, I want to look for second primary tumors, sir.
Right. What is the incidence of second primary?
Sir,
And
in
when do you
oral
call it a
cavity,
second primary?
so second primary tumor incidence is around 2 to 8%. Warren and Gates have given criteria for defining a second primary tumor. The according to the criteria, the primary tumor and second primary tumor, they should be histologically proven as as carcinoma, and then that second primary should not have been a metastasis from the primary. And the third is the intervening mucosa between the two tumors should be at least more than 2 centimeter. Then one more definition has been added that it can still be a tumor which is within 2 centimeter of the lesion can still be considered if the interval between the first primary and the second is at least more than 3 years duration, sir.
Okay, go ahead.
But Smita, what definition the Warren and Gates criteria that you said second primary, that is after, so that is after the initial treatment, right? So now if you have, what is the difference between synchronous and metachronous
So if it is occurring with the
primaries?
primary lesion within 6 months, it's synchronous. Metachronous is more than 6 months duration, sir.
That's right. So in this case, you're trying to look for a synchronous primary, isn't it?
Synchronous, yes, sir, as well. That is also
So I think
type of
that was the question actually. So how frequently do you see synchronous primary in other sites in advanced total cancer?
yes, sir. The incidence is sir, around 2 to 8%, sir.
Both synchronous and metachronous?
Um,
Right, no
sir,
issues. We'll proceed. Yeah.
yes, sir.
Why do you say it's T4?
T4, sir, because there is skin puckering present around the alveolus, sir. Sorry, around the commissure of around 2 into 2 centimeter, and as well as because of paramandibular spread of disease, I'm anticipating that is mandibular erosion. So I would like to consider it as T4A, sir.
Right. Skin puckering per se, so what is the T1 to T4? I mean, the staging, that is, if we can just say that.
So according to the 8th edition AGCC, which has also incorporated depth of invasion, sir, T1 is less than 2 centimeter or DOI is less than 5 mm. T2 is 2 to 4 centimeter or DOI is less than 10 mm, or less than 4 centimeter DOI is 5 to 10 mm. T3 is more than 4 centimeter or DOI is more than 10 mm. And T4A is any oral cavity malignancy if it's involving the skin, erosion of the mandible or the maxillary sinus, involvement of the erosion of the maxilla or involvement of the maxillary sinus. And T4B is involvement of the skull base, internal carotid artery, or involvement of the masticator space or erosion of the pterygoid cancer. Or
So that's right. That's correct what you say. So skin puckering per se will not classify it as T4A. Though I take your point that since there is paramandibular disease, there could be erosion. But again,
Yes, sir.
clinically, of course, you need to confirm it with radiological evaluation.
Yes,
So
sir.
clinically, you again say there is no loosening of teeth.
No, sir.
So it's okay. I would go take your your T staging at this point.
Yes, sir.
Yeah, please proceed. So how would you go further?
Sir, okay. So my provisional diagnosis, as I said, it's a carcinoma right buccal mucosa, clinically T4A N1 NM0, so stage 4A. So I would like to work up the patient. I would like to treat the patient with a curative intent, that is surgery followed by adjuvant radiation plus minus chemotherapy. So with my workup along with the routine investigations, I would like to get a biopsy of the lesion, as well as I want to get a contrast enhanced computed tomography, which involves the oral cavity, neck, and NCCT of the thorax for my ruling out of distant metastasis and second primary, sir. With the
So yeah, Smita. So how would you take your biopsy here?
So biopsy, I would like to take from the most representative site of the tumor, not trying to take it from the center. Uh, so from the periphery and the growing edge of the tumor, I would like to take my biopsy, sir.
So, is the
Why so?
representative, so is the
So
representative
because
Please.
tissue always, why is the representative tissue not the center?
I am not able to hear you, ma'am.
Why is the representative tissue not the center of the tumor?
Mostly because of aggressive multiplication of the malignancy, ma'am. The center of the tumor mostly has necrotic material, so we want to look for the growing edge of the tumor.
So by growing edge, will you also include the normal mucosa?
So no, ma'am, normal mucosa, if I'm taking punch biopsy, if I'm taking incisional biopsy, then I would like to take the growing edge of the tumor as well as the intervening mucosa to look for invasiveness of the tumor as well.
You mean the edge, meaning the normal mucosa as well?
The edge is the proximity mucosa around the proliferative
So
component of the tumor.
while I agree with your justification that the center of the tumor generally has necrotic tissue, I do not agree with the fact that you need to take the normal mucosa to see invasion. So the representative tissue will be the one which is around the center, but definitely not involving the normal mucosa. So regardless of it being an incision biopsy, punch biopsy, it does not need to be with the normal mucosa, because the normal mucosa is the one which will bleed and it will be extremely painful.
Yes, ma'am.
So right. So you've done a biopsy. What will you do next?
With my biopsy histopatological confirmation of malignancy, I would like to also do a radiological evaluation because it is already T4. I'd like to get both of these two investigations done simultaneously: contrast enhanced computed tomography of the oral cavity, neck, and sir NCCT of the chest.
So is there any particular technique with which you would want to do CCT for oral cancer? Of course, this is advanced, so may not matter much. But then for early lesions.
Sir, I would like to get a CCT done with a puff cheek technique, sir.
And why so?
So because of the tumor burden, even in this case, uh, according to the scan, because of the tumor bulk, we are not able to appreciate the involvement of the various subsites of the oral cavity. The tumor bulk might just be sitting on the upper or lower alveolus and might not actually be involving the same. So we want to rule out and we want to see the involvement of the tumor, either on the buccal side, involvement of the buccinator or involvement of the mandible. So in that way, we want to see the depth of the tumor, which is free or overlying the associated buccal
Right.
mucosa.
So do we have the imaging pictures of this patient to discuss further?
Yes, sir. I think ma'am is playing it on the screen.
Srita, before you go there, do you want the CT of the head, neck, and thorax? Do you want a PET CT or CT scan of the head, neck is enough?
Sir, CCT is enough, sir.
You said this is stage 4. Do you want to screen for distant metastasis? Do you want to screen the thorax, lungs? You want to
Sir,
PET?
I've already asked for NCCT thorax, sir. I think it would suffice. There is no clear-cut level 1 evidence for PET scan in a case of a fresh primary, sir. But in cases where there is bulky and extensive T4, tumor, and then if they are bulky level 3, level 4 nodes, then we can go ahead with the PET scan, but still not a strong recommendation, sir, in a fresh primary.
Right. What is the incidence of metastasis at primary?
Distant
Or
metastatic,
stage 4?
sir, it's around 5 to 15%.
That's about 4-5%. Okay, go ahead.
The
So,
scan,
yeah. So again, just going on with what Sir asked. So
yes,
you
sir.
said CT thorax is good enough, right?
Yes, sir.
Why so?
So because the most common second primary or distant metastasis in a case of oral cavity malignancy is lungs, sir.
Correct. Can you classify? I mean, say anything further beyond that?
Sir, and also for my pre-op evaluation, I mean,
Right. So
for
no, the point
general
here is that the incidence of extrapulmonary metastasis in the absence of pulmonary
pulmonary,
metastasis is very rare.
yes,
So
sir.
if you can, in oral cancer, that is.
Yes, sir.
So if you screen the lung, it should be good enough. It should be a good enough evaluation to rule out distant metastasis. And as you rightly said, in case of bulky N3 nodes or low level 4 nodes or bilateral lymph nodes,
Yes, sir.
you would probably want to do a PET scan in an upfront case.
Yes,
Okay.
sir.
So what next?
So on the basis of CT scan, there is a paramandibular disease extension, and also at the level of premolar to molar, there is a small point of cortical erosion, sir. And she has around 2 into 2 centimeter lymph node stationed at right level 1B with no other features. So I would now solidify my diagnosis as T4A and 1M0, sir.
Is the masticated space involved in this patient?
There is abutment of the masseter with loss of fat planes, sir.
So if it is involved, how would you stage it?
So now if there is, because there is no gross extension of the masseter, but there is abutment of the masseter, and if it is involved, I would stage it as T4B, sir.
Right. So is the masticated space subdivided further?
So masticator space is subdivided further into superficial temporal space, deep temporal space, pterygomandibular space, and masseter space, sir.
No, my question was, is the masticated space, divided, clinically, in terms of, in relation to any anatomical landmark there?
Masticator space, sir, it is mainly confused with, it is mainly comes in
Correct.
relation with the infratemporal fossa space, sir. So
So what is the difference between masticated space and infratemporal fossa? Is there a difference?
yes, sir. If we subtract masseter from the masticator space, then that involves the infratemporal fossa space. So ITF is a non-facial line space, whereas the masticator space is a facial line space, and also the medial boundary of the ITF is the lateral pterygoid plate. But when we talk about the masticator space, it goes till the medial pterygoid plate, sir.
So is the mandible part of the infratemporal fossa or the
Mandible.
masticated space?
The mandible is the actually mandible. The ramus of the mandible is comes under both ITF as well as masticator space, but the involvement of the body and the ramus of mandible along with the masseter comes under masticator space, sir.
Actually, the mandible and the the masseter, mandible, medial pterygoid together forms the masticator space,
Yes, sir.
right? So the deep layer of the medial pterygoid, the mandible, masseter forms the masticator space, whereas the other, head of the medial pterygoid, the lateral pterygoid, and the pterygoid plates form the infratemporal fossa.
ITF.
So the
Yes,
mandible is not part of the infratemporal fossa, right?
yes, sir.
It's part of the masticator space. So there's a subtle difference. You said it well.
Yes, sir.
And is the infratemporal fossa again divided further?
So ITF has been divided, compartmentalized into. There was a study done by Liao et al., which has divided ITF into a supranotch and infranotch area. So the in a transaxial plane, when we divide along the sigmoid notch, we have a supranotch and infranotch disease, which is prognostically important, as saying that infranotch diseases, they behave better and they are prognostically better than supranotch. And as well as the Mahajan et al. Has compartmentalized into low ITF and high ITF. High ITF is further divided into anterior high ITF and posterior high ITF. So in the low ITF, we can still get away with surgery, and high ITF patients might need NACT to downstage disease, or in a supranotch, we can straight away send the patient for CPRT, sir.
Hey, do you have any textbook or anything open in front of you? How do you manage to say everything so fluently?
Nothing like that, sir.
Okay, I'm just pulling your leg. It's okay. So I have nothing much to ask. You can
Sunita,
carry on.
So,
Sunita,
okay.
Mitali, go ahead. Mitali, go ahead.
No, sir, please go ahead.
Sunita, you've done a CT scan. Is there any indication or what is the indication of adding an MRI in a case of a buccal mucosa or a CA alveolus?
Sir, indication of MRI, especially we need to know if we need to know for marrow invasion, and it helps us to know for help us to get the idea for perineural invasions. Sir. These are the two indications from which MRI will be complementary to CT scan, sir.
Yeah. So the answer is, if you have exposure of the bone on CT scan, which is going up to the marrow, it's better to add a CT scan. That
Yes,
will
sir.
tell you where the marrow intensity is lost and where you need to take a cut, because that is not very well seen in CT scan.
Yes,
And also,
sir.
as you said correctly, whether there is any perineum. Okay. Mitali,
Yes,
your
sir.
question, please.
So, Sunita, since you're answering ITF so well, is there any way you can clinically judge whether the patient has a high ITF involvement versus a low ITF involvement?
So, ma'am, if there is a patient presence with severe trismus, if there is infiltration of the temporalis, then patient develop presence with severe trismus, and if there the clinically on palpation, if the bulge around the buccal mucosa is bulge is seen significantly over the mandible, ascending ramus of the mandible, or the bulge is going till zygomatic nerves, ma'am. So in that cases, we can clinically judge that the patient has supranotch disease, ma'am.
Partially, but does it have, can you tell me whether you can judge whether the patient has high ITF in terms of pterygopalatine fossa involvement? If there is pterygopalatine fossa, how does it clinically present?
Pterygopalatine fossa involvement, ma'am, they can be loss of sensation over the, we can sensory, we can test, ma'am, loss of sensation over the cheek, we can see for the distribution of the maxillary nerve, and also pterygopalatine fossa involvement, the tumor might go medially and involve the nasal cavity, nasopharynx. So in that way also
Does
assessment
it
of
have
the,
anything to do with lacrimation?
yes, ma'am, if they can be because it's the medial boundary is the spinopalatine foramen. So from that area, if it grows medially, then if it involves the nasal cavity and the
No,
nasopharynx, then
it has something to do with the parasympathetic nerves, but good enough. Okay, go ahead.
So what next? How do you treat this patient? You have evaluated, staged. Now what next?
sir, I'd like to treat the patient with curative intent, which is surgery, and with for the surgery, I would like to do excision of the tumor, or taking at least around 1 centimeter of margin all around the tumor, along with the involved skin, as well as segmental mandibulectomy, then neck dissection covering levels 1A to level 5, sir, and with reconstruction of the defect.
Why 1A to 5, Sunita?
Because
So
this is
what is the diagnosis? What is the biopsy report of this patient?
a squamous cell carcinoma,
Well differentiated,
moderately differentiated.
moderate differentiated. Why 1 to 5? What
So
if I do
because
1 to 3? Is that sufficient?
Sir, 1 to 3 evidence we have for N0 neck, sir. But in a case of N positive neck, regularly we do MRND addressing all the levels, though the incidence of level 5 metastasis is just around 3.3%. But in a N positive neck, there is no level 1 evidence as not to addressing all these stations in an N positive neck. But MRND is usually done for N positive neck, sir.
Would you like to confirm that node positive on
We
table?
can intraoperatively
Yeah.
go ahead and get a frozen
Yes, you're
section
right.
done.
For N0, you would do a 1 to 3 or 1 to 4, and if that node comes positive, especially level 2, level 1 doesn't make so much of a difference. But if
Yes, sir.
level 2 is positive, then you'll add level 4 and level 5, especially for a buccal cancer.
Yes, sir.
So, Sunita, one more question. If this case the skin is puckered, but if you didn't have puckering of the skin, how do you decide in a buccal cancer whether you would excise the skin or not excise the skin?
So my level of involvement should be buccinator. If buccinator is not involved, I can still get away with not excising the skin. But if buccinator is involved, then I would like to remove the skin as well.
No, okay, good. Go ahead.
Sunita, why do you aim for a 1 centimeter margin?
Ma'am, because at least according to the classification of margins given by the Royal College of Pathologists, they have set clear margins, positive margins, and close margins as more than 5, 1 to 5, and less than 1. So at least to get a 5 margins, I need to minimum give a 1 margin, 1 centimeter margin around the tumor, ma'am.
Why? What happens between
Because there are various
incision
issues,
and
ma'am. First of all, there is tumor shrinkage because of various intrinsic and extrinsic factor. Intrinsic factor because of tumor, the intrinsic properties of the tumor as well, the size and the inherent uh, property of the tumor to constrict on itself, and the extrinsic factor
tumor
is because
constricts or the margin constricts?
the actually, ma'am, that is the intrinsic factor of the tumor. The other thing is because the tumor will be sitting over the buccal mucosa. Once we excise the tumor, that stretched buccal mucosa also constricts. So in that way, combined, at least 25 to 30% of tumor shrinkage is there. And apart from that, when we send the tumor in formalin, additional 10% constriction, contractility is there. So because of which we might compromise on the margin. That's why at least 1 centimeter margin
Okay, good.
is warranted.
Okay. So, Sunita, when will you address the contralateral neck?
Contralateral neck, ma'am, is addressed whenever there is a midline bulky tumor. If there is a tumor or any tumor which is reaching midline or crossing the midline, we would like to address the contralateral neck, because in such a case, the incidence of contralateral neck metastasis goes as around 10%, ma'am. So we would like to address the contralateral neck as well.
So, your decision making for addressing contralateral neck is purely based on the extent of tumor or anything else as well?
Extent of the tumor as well, and also on the basis of if the patient has level 1 lymph node positivity is there, still we can also we will go ahead with contralateral neck node and also if the patient has contralateral neck node positivity preoperatively.
So, what are the options of reconstruction in this patient?
Ma'am, your audio is very.
So, what are the options of reconstruction for this patient?
Ma'am, reconstruction, because it is through and through defect, there is extensive, there would be a significant amount of soft tissue loss for this patient. So I would like to give the option for the soft tissue reconstruction, can be in the form of free flap, which would be my first patient. Still, I would discuss with the patient in the form of anterolateral thigh flap and make bipedal it. Otherwise, PMMC, pectoralis major myocutaneous flap, is also an option, but since she is a female, I would not keep it as my first choice.
And so, you considered a segmental mandibulectomy in this patient, right?
Yes, ma'am.
You preserve the posterior segment.
Ma'am, because in cases of lateral and posterolateral segment defects, I would still get away with soft tissue reconstruction without bony reconstruction, ma'am. That would
What
still
is the
do the
difference between central bone segmental mandibulectomy and posterior segmental mandibulectomy?
central arch defect needs bony reconstruction, because if after removing the central bony defect, if you only reconstruct with the soft tissue defect, then first of all the entire tongue and the associated muscles will fall back because there is no support, and at the same
What is
time,
that support? What is that bony landmark you're looking which
ma'am,
you lost?
genial tubercle and attachment of the genioglossus, geniohyoid, and the mylohyoid.
Okay.
When would you not consider upfront surgery for these advanced oral cancers?
Sir, in cases where there are borderline tumors, as defined by Patil et al., if these tumors are extensively involving if it's involving ITF or the buccal mucosal carcinoma cancer, which with diffuse edema reaching up to zygomatic arch, or if it has skin infiltration, or if it's a tongue cancer reaching till hyoid or vallecula, in such cases, in borderline resectable cases, we can go ahead and think about any CT and try to downstage the disease, sir.
Right. Nice. I have no further questions to ask.
Hello, Sunita.
Yes, sir.
Yeah, so now you've done reconstruction. You said you'll put a soft tissue flap or a bone. Bone flap is the choice, isn't it?
If I would get away with the soft tissue reconstruction, a soft tissue flap, but I would still give the option if the patient demands for dental rehabilitation, then fibula would be the first choice. But because she has extensive soft tissue defect, fibula would not be sufficient. So fibula can only cover the inner mucosal defect. For the external defect, I would she would need double flap reconstruction.
Sunita, when
So
you
with
talk
the
in an exam, ideal should be an ideal reconstruction. The basic principle or premise of a plastic reconstruction is like for like. So if you are removing bone and soft tissue, you have to replace bone and soft tissue. Okay?
yes,
Don't
sir.
because of constraints we do various other things, but the principle is basic principle is that when you have the best modalities available, it should be like for like. Because if you do a
Yes,
soft tissue, this your cut is going to come nearly to the center or just paramedian. You're going to have jaw deviation. She's going to have problems with mastication. So it's not only about long term cure, but it's also about quality of life.
yes,
Okay.
sir.
So
Yes,
ideally, you should when you resect bone and you can have two ends of the bone, you should reconstruct with like for like. So if you are removing the bone, you should replace with the bone. Okay.
yes, sir.
Getting away, you can get away with anything.
Yes,
Okay.
sir.
That should not be your answer that I'll get away with this. Okay.
Yes, sir.
All right. So now you operated this patient. What is the chances? How you are going to counsel? What is the post-operative? What you have the HPR of this patient?
No, sir. She was pre-op patient, sir.
Right. So if your node is positive, what would you give the patient post-operative?
So post-operatively, if more than two positive notes are there, then I would consider for adjuvant radiotherapy, sir.
For a single positive node, you're not going to consider adjuvant radiotherapy.
Single positive note, according to NCCN guidelines, also does not recommend. We can keep the patient under close follow-up, but still that has to be decided with the multidisciplinary committee, as considering other other histopathological risk factors if it all fits, and also seeing as I said, other histopathological risk factors. Then I would take a call on addition of adjuvant
Again, Sunita,
RTT.
NCCN guidelines or any guidelines are based on any evidence. So what is the evidence for in a squamous carcinoma, P16 negative, that you can avoid radiation as of today? P16 positive, yes, there are some articles. What are the articles for P16 negative squamous carcinoma of the buccal
Sir,
mucosa?
for this, the study was done by Ang et al., which had told that nodal positivity, if it's only one, then adjuvant RT might not be recommended, and the patient can be kept under follow-up. If it's more than equal to two, then adjuvant RT is to be added, sir.
Is that correct, Shiva? I'm not so sure about this study because all the study that I've read is not for squamous carcinomas. Is Shiva around? Anyway, Sunita, please share that article.
Yes, sir.
According to me, for squamous carcinomas, the current recommendation still, we do not have enough evidence to say that you cannot give radiation for a single node positive. Shiva, you
So, okay, that single node, that which article? Sorry, I missed it in between, sir. Sunita, which article you quoted for that?
Sir, Ang et al.
Okay, is it a recent article that you're quoting, or?
So it's not so recent, but I forgot the year. But I
Okay, there
read.
is a recent article which says for such a situation N plus, it is a prospective observational study. I mean, they started it as randomized, but it couldn't be done. But they do say that it can be considered. But still, there is no, as you say, high level of evidence is not available as of yet.
Yes, sir.
But in e-cancer, this was published just about earlier this year.
Yes, sir. Sir, I'll have a look, sir.
Yeah.
Thank you, sir.
Sunita, what do you will be post-op RT? Do you radiate ipsilateral or do you radiate bilateral? What would your radiotherapist do? What is
So
practice?
they irradiate bilateral neck, sir.
Why bilaterally? If you
So
think the
bilaterally,
are going bilateral, then why didn't you operate the opposite side?
so usually if it only single side irradiation is done, still the chances of contralateral neck mets, if it's not bulky or crossing the midline,
Chances of contralateral mets, you should have operated the opposite side. What are the chances of contralateral mets in the ipsilateral buccal cancer? Not
sir,
crossing midline.
Sir, 10%, sir.
10%.
Yes, sir. According to the SENT trial which was done, sir, because when they tried to do a sentinel lymph node biopsy, they found the occurrence of lateralized tumor of around 10% in the
No,
contralateral.
I think that's a wrong example that you're quoting, Sunita. You're doing well because SEN trial is for early oral cancer.
Early cancer. Right?
So you cannot take that for this in an advanced situation. We do have articles in for advanced oral cancer where contralateral neck can be positive. Can you name what are the situations where that will happen in lateralized, buccal mucosa GBS lesions such as this?
So there is a study by Tata Group by Dr. Bikramjit et al., where he has told the incidence of contralateral neck metastasis in a lateralized buccal mucosa cancer, which is sir around 4 to 7%. So not
No,
very much.
and so that Bikramjit's paper is for tongue, which is at or crossing midline. But there's one more paper by Manish Meher in Indian Journal of Cancer for lateralized, lesions such as this. In the presence of ipsilateral N plus neck and presence of, fungating skin lesion, the chances of contralateral metastasis is higher, right?
Yes,
Please go
yes,
through
sir.
that paper.
Yes, sir.
So, Sunita, there's no consensus on treating the contralateral neck currently. We are working on that. But any lesion that approaches or crosses the midline, you must address the contralateral neck. And the second indication, probably for at least radiating the contralateral side, of course, you operate the contralateral. If you get 1A positive, you do opposite SOHD. And the other indications probably is multiple ipsilateral nodes. So that is one more indication where the radiotherapist may treat. There's no evidence for that currently. But yes, if you have multiple ipsilateral nodes, that is the place where you would probably try to treat bilaterally.
Yes, sir. Thank you, sir.
Any other questions?
No, sir, none from my end.
I think we have also reached about 7 o'clock. So, Komal?
Yes, sir. Sir, I think we can start by giving marks out of 10 to Sunita, sir.
Don't give full. I normally give full.
Okay.
Yeah,
Did well.
I think, yeah, she did well. I agree with sir. She did well. You need to continue to, do the same good work. Yeah.
Thank you, sir.
Mitali, ma'am?
Yeah, I agree with the other two. You did quite well, Sunita. But yeah.
Mitali, you're not heard. Mitali is like slightly strict. She'll give 5.
No, sir. I completely agree with the two of you. Sunita, you did well. But
Thank
now
you.
you should read more to earn some brownie points.
Yeah. Thank you, ma'am.
So, I think we conclude the session now.
Yeah, thanks.
And thank you, Mitali ma'am, Shiva sir, Chaukar sir, for sparing the time. Thank you so much.
Thanks, Komal.
Thank you so much.
Thank you, Sunita. And thank you to all the participants. We'll be back after 15 days with another topic, another set of examiners, another presenter, another talk. Thank you. Have a good evening.